class. Welcome to part 2 of chapter 35 from our Henningsen book, second edition. So we left off talking about chronic thrombus and the differences between acute and chronic. So we're going to pick up on superficial vein thrombosis on page 427. So we've been talking about, thus far, we've been talking about a deep vein thrombosis. So now we're talking about a superficial vein thrombosis, which the information is almost exactly the same. It's the same thing. It's a vessel that has a thrombus in it. The difference is, so obviously it'll be non-compressible. There will be echogenic material filling the lumen. The difference is that you can see it from the outside, and that's because it's located in the superficial veins. So on page 427, SVT is usually diagnosed clinically with a painful superficial cord and surrounding erythema, which is redness of the skin. So oftentimes they don't even really need ultrasound for this. It can be diagnosed clinically, which means the doctor could just look at the leg and figure out what's going on with the redness of the skin and that superficial cord where like the thrombus is just underneath the skin in a superficial vein, and you're feeling that hardness of the thrombus. This condition is treated with anticoagulation therapy. So patients would be given medication, blood thinners, to help with the coagulation process. So like to not coagulate, to not clot as quickly as it did. They want blood to be thinner, less viscous, or with ligation of the offending vessel at the proximal attachment to the deep system. So sometimes people think that it's not that scary to have a thrombus in the superficial veins because it's the deep veins that go directly to the heart. And so they're like, a lot of people think that it's more dangerous to have blood clot in the deep veins because of because the way the blood travels to the lungs and the heart. And that is true. But also you have to keep in mind that the superficial veins are connected to the deep veins, typically by perforators, but it's sometimes not, right? So like, for example, in our ultrasound image, you have the common femoral vein here, and the common femoral vein is the deep venous system, and then you have the greater saph coming off like this, right? So this is the common femoral vein, the deep venous system. This is the greater saphenous vein, the superficial. Well, if you have a clot here in the greater saph, this one, the greater saph is connected to the common femoral. So this is a direct connection, right? So this clot could easily just go right through, go into the common, which now it's going to be in the deep venous system, and then eventually to the heart. So I guess like they're both kind of worrisome, having a clot in the deep and in the superficial, but I do think that more people are concerned with having clots in the deep than in the superficial. Either way, one thing that they could do is they could put the patient on blood thinners, which is a form of anticoagulation therapy. Or number 2, they can kind of tie off the proximal attachment to the deep venous system. So they can actually tie this like connection off here so that that clot cannot actually travel into the deep venous system. On the next page, you want to know that there's a higher prevalence in women and of superficial venous thrombosis. 60 to 80% of them are seen in the greater saphenous. Also, you want to know that the hallmark of superficial vein thrombosis is a very painful but palpable cord-like structure. The sonographic appearance is exactly, or it says similar findings to that of the DVT, but this time it's within the superficial. So this is what it looks like. This is what a superficial vein thrombosis looks like. It looks exactly like like a DVT, like a blood clot in the deep venous system. There's echogenic material filling the lumen. The lumen will not be compressible, so when you're trying to coapt the vessel and transverse, it won't fully coapt. And the only difference is, if you notice, like how superficial it is very close to the skin line. So and also not only is it close to the skin line, you're going to notice it's not paired. It is solo by itself. It does not have its paired artery. And that right there should tell you that this is a superficial vessel. So I have never found a protocol to scanning the superficial veins. Now, you may work somewhere where they do give you a protocol for superficial veins, and if they do, that's awesome. However, everywhere I've worked, it was more so of scanning the area of interest. So the patient would come in and they would know exactly like the area that's red or that's painful, or the area where they felt that cord-like toughness of the tissue. And so they would be able to palpate it. I would also palpate it. I would also feel it. And then I would scan over that direct area. And then I would, take my pictures in transverse. And of course, I would try to compress it to see if it was compressible. If the lumen truly does have thrombus, it's not going to be compressible. And then I would turn in long and I would show it with color Doppler, and I would do my pulse wave Doppler on it. But obviously, remember, it's important you guys remember, number one rule is you are not allowed to augment. So I would do my color Doppler, I would do my pulse wave Doppler, but I definitely wouldn't augment flow, because you're never allowed to augment once you find a positive DVT in any of the veins in the leg. So this is a superficial vein that has a thrombus. Okay, our next topic is venous insufficiency. And so it says venous insufficiency is also called reflux and occurs when valves are incompetent. So sometimes people use the words venous insufficiency or valvular insufficiency. That they use them interchangeably, so kind of like AKAs, and you can do that. So really, valvular incompetence, right, which means the valves are not competent, so they're incompetent valves. That means they're not working as they should. They're not opening, closing as they should. So valves that are incompetent cause venous insufficiency or reflux, right? And so it's like one kind of leads to the other, but a lot of times people use them as AKAs. It says incompetence allows blood to flow backwards towards the ankles, right? Towards the feet. The superficial venous system is a common site for valvular insufficiency that leads to varicose veins. So you can have incompetent valves in the deep system or in the superficial system, but it's more common in the superficial system. And then if valves are incompetent in the superficial system, that means blood is going to be slowly going backwards towards the feet, like in the retrograde fashion. And so that's obviously the purpose of valves, right? To not allow that to happen. But the reason it's happening, right? The reason blood is going back towards the feet is because the valves are incompetent. And then the valves will swell up. I mean, the veins will swell up with blood. And that's why we see the spider veins or the varicose veins on the legs. So again, it says the superficial venous system is a common site for valvular insufficiency, and that will lead to varicose veins. If the venous insufficiency occurs because of a DVT, it is termed secondary. If the venous insufficiency exists without a DVT, it is termed primary. So when you think about venous insufficiency, it has to do with non-functioning valves. So why are those valves non-functioning? So they could just be non-functioning, right? Just because they're not working properly. And then that would be called primary venous insufficiency. However, if the valves are not working because the patient has a blood clot that is causing the malfunction of the valves, right? Because blood clots, they can form anywhere. They can form, you know, right next to a valve, right over a valve, like wherever they want. So if your valve is not working properly, your valves are not working properly because of a blood clot, they could term it secondary venous insufficiency. Secondary venous insufficiency is also termed post-phlebitic syndrome, meaning that the DVT is what damaged the valves beyond functional capacity. It says high frequency linear transducers can be used to document the valves in motion. So you would use a high frequency number one, because you got to keep in mind this usually happens in the superficial system, not always, but it usually happens in the superficial. So those vessels are right underneath the skin line. You don't need to have that much depth of penetration. You can just use that high frequency, but also you're documenting moving valves. And so it's very challenging to do. Valves are, they almost look like a hair that is like flapping around at the inside of the vessel. They're not very obvious. And so the higher the frequency of the transducer is, the more detail we're going to see. So what are you going to expect to see on the spectral Doppler? It says spectral Doppler shows reverse flow during Valsalva. And then it says a proximal compression or Valsalva should halt venous return. So when the patient does the Valsalva maneuver, or when you're doing a proximal compression with your hand, remember that just means pushing above your transducer, not below. What you should see is the absence of flow, and that is good, right? That is like what we want to see. However, if that flow continues when the patient has done Valsalva or you have done your proximal compression, that's when the valves are determined to be incompetent or not functioning to their full capacity. Sonographers can evaluate for venous insufficiency or for reflux by performing a proximal compression with pulse wave Doppler to know a complete lack of flow during a proximal compression, or having the patient perform the Valsalva maneuver to terminate venous flow. If the valves are competent, there is no Doppler signal until the pressure is relieved. A sonographic finding of venous insufficiency is the leakage. So this right here, guys, where the flow continues even after the patient has done Valsalva or even after you have done your proximal compression, is called leakage. That means that the flow is leaking backwards towards the feet and the ankles, when in fact it should not be. There should be no flow. It's like leaking retrograde, leaking backwards towards the feet and the ankle. As demonstrated by a Doppler signal during the proximal compression or Valsalva. So leakage is a demonstration of a Doppler signal once you have already done the proximal compression or the Valsalva maneuver. A hallmark of venous insufficiency is when an aforementioned provocative maneuvers cannot halt blood flow. So they're just saying venous insufficiency is proven when your proximal compression or the Valsalva maneuver has not stopped the flow. All right, now still kind of continuing on a similar path, we're still talking about varicose veins. Varicose veins are veins in which the valves have become damaged and are leaking to the point of venous wall distension. And this is an AKA is spider veins. So there's so much leakage. Remember what leakage is? It's where blood is leaking back towards the feet. There's so much leakage that now the venous walls are distended with like an increased volume of blood. And that's why the veins get so big and they look like this, right? I highlight that the veins appear very superficial and are dilated and can be seen bulging out from under the skin. Primary varicose veins occur as a malformation of valves. Secondary varicose veins are acquired from damaged from a disease or a DVT. Overweight women of increased age with a family history of varicose veins are more susceptible. Other contributing factors are professions that include standing or walking for most of the day. Historically, the treatment of varicose veins was vein stripping, which involved making an incision to remove the vein. Current treatment involves less invasive procedures, including injections, lasers, and radiofrequency energy. And so you guys don't have to know, they talk about sclerotherapy. You guys don't have to know the rest of the treatment because that's kind of like outside of what we would do as ultrasound. We do, like I said, we do scan varicose veins. Patients like typically don't like the appearance of varicose veins. And sometimes we scan them, and then sometimes they also have a thrombus within them. And we looked at that a couple minutes ago. So a more invasive technique that has been done is where they do an incision next to the varicose vein, and they kind of like pull these varicose veins out. So they pull the veins out, and then less invasive than that, than like stripping them out of your leg, would be injections, which injections will kind of like not like fully disintegrate them, but like make them reduced in size, so like less visible, because it's typically like a aesthetic issue. Like it's not that they're horribly painful or anything like that. It's just like people don't like the way they look, and so they usually seek treatment for them. And so this is what they look like on ultrasound as well. You're always going to see them. And so I would write this down in my pocket notebook. I'd write some information about varicose veins. I would write down, number one, what they look like. They're always going to be very, very superficial. Now you got to keep in mind that these are not going to be straight vessels. So they're all kind of like kinked over each other, like almost like a little ball of veins. And so you're going to see them like that on ultrasound, right? Like you're just going to see like, this is a piece of the vein, this is a piece of the vein, this is a piece of the vein, this is a piece of the vein. So they're superficial, and they kind of look more like bubbles at the top of your screen. If you turn your transducer on one of those bubbles, you'll see that it like turns into like a line, but it only looks like a line for like a small section, because then it probably takes a turn, and then our ultrasound can't take turns with anatomy without us having to turn or rotate our transducer. So sometimes it looks more like little circles or little bubbles at the top of our screen. Sometimes we'll see like little linear sections. And if they are just varicose veins and they do not contain a DVT, you could compress all of them out. So just like even the, like slight transducer pressure, you'll see that you can compress them out. So I will compress them if I'm scanning for varicose veins. Like we just want to make sure they're just varicose veins and there's no clot. I do compress the different sections, so I'll do a dual screen with and without compression. And then keep in mind, I would also write in my pocket notebook that sometimes you can find a DVT within a vein, a superficial vein, and it'll look identical to like a deep venous thrombosis. It's just more superficial in the leg. All right, our next topic is phlegmasia caerulea dolens. Phlegmasia caerulea dolens. I know these are new words, but you want to make sure you're saying them right. So caerulea means blue, which is referred to as the color of the limb. Phlegmasia caerulea dolens, or PCD, is highlight that it's uncommon, but it's a severe form of acute DVT. So it is a acute DVT, which means the patient has probably never had DVT before, but it's like a very severe form of DVT, which is usually proximal to the area of the limb. So it's usually a severe DVT in the proximal arm or the proximal leg. Well, we're talking about legs today, but you want to keep in mind that any vein in the body anywhere can develop a DVT. So, and then keep in mind that proximal for us as sonographers, any part of the leg that's closest to the heart, that would be considered the proximal portion of the limb. Highlight, blood cannot leave the leg owing to the DVT. So it can't leave the leg because there's a DVT. It pools and it accumulates, causing a bluish tone of the limb. So this is typically what it looks like. The patient's leg looks pretty bad, right? Like there's a severe discoloration. It just like you would be able to instantly see it, because like they said, it's a pretty severe issue. And so typically what you'll see here is you'll see the patient will have a DVT, and everything below the level of the TVT. So it's acute DVT. So remember, the TVT is going to be homogeneous. It's going to be big. It may show a little bit of movement or flapping around the inside of the vessel. It's going to be like somewhat compressible. Remember, we're going to think of jello. And so, um, wherever you see that big giant DVT, the leg underneath that, or like more distal to that, is going to have that bluish color. So it's kind of hard to tell with this one because it does look like, this is like the more severe area here, but I also think like this looks a little bit abnormal. So it's kind of hard to tell. Like initially I thought like the DVT would be somewhere here because all of the discoloration distal to that, right? So this is like the proximal DVT here. But I don't know, because this is also kind of like confusing me here. So this, I'm assuming here, but like this patient may have a DVT, somewhere up here, and everything underneath it, everything distal to that proximal DVT is what is taking on that cerulean tone or that blue tone. It will have a painful limb. It looks painful, edematous. It may be swollen. Um, if it is left untreated, it will lead to venous gangrene, phlegmasia albidolens, limb amputation, and death. So if it is left untreated, and sometimes you'd be surprised, right? Like, how could someone not seek help when they have this? But we have seen some pretty wild things, and things pathologies that have been going on for some time, but you never really know. Like, some patients are, they say ignorance is bliss. Like, sometimes people would rather remain ignorant than like, if they're really afraid of getting bad news, they may like choose to remain ignorant and not seek medical help until like, it's kind of like they're forced to it because the pain is so bad. Or maybe it's sometimes, usually family members will bring patients at that point. Maybe they don't have health insurance, maybe they're, afraid to seek medical advice for whatever, different reasons. But if it is left untreated, it could turn into gangrene, something called phlegmasia albidolens, which we're going to talk about in a few moments, or a limb amputation or death. So let me show you what gangrene looks like. So gangrene is like the worst of the worst, guys. I have scanned patients like this. Okay, so like Orange County, LA County, where you're like, okay, people have access to healthcare and like no one's going to let things go this far. Yes, they do. People go this far before they seek medical attention. And what gangrene is like tissue necrosis. So like it's literally the dying of your tissue. That's why the bottom of her feet, the toes are all black, because like literally her toes are dead. And then the tissue above it is starting to die and like slough off, like dead tissue just kind of shreds off of the bone, and that's what's happening. It looks horrendous, right? When you see it, you would probably only see it if you worked in a hospital setting, but if you see it, it's like, I mean, just looking at this picture is hard to stomach, right? But let me tell you guys something. As an ultrasound tech, you guys, if you work in a hospital, you will come across gangrene. The smell is like something you will never forget. The smell of gangrene, you can walk into a room and just like instantly you're like, gangrene, like you can spot it from like a mile away. I should say you can sniff it from a mile away. I used to work in a big hospital, and when I would walk into the emergency room, 3 seconds through the door of an emergency room, I would say, okay, who has gangrene? Because it will flood the entire room of stench. And it's just really hard as an ultrasound tech to work in a situation like this. Not only are you completely enveloped in this like horrendous smell, like it's the smell of death, right? But it's like you can't even focus through it. It's so bad. And it's also very messy. Like you're like afraid to touch the leg. Patients, it's kind of crazy because you expect them to be in more pain than they actually are, but like you also have to keep in mind this tissue has been dying for some time. So like the patient probably has a higher pain tolerance, but also like the tissue is dying. So like dead tissue no longer really hurts. So sometimes they'll complain of pain, but I always kind of expected their pain response to be higher than it really was. Like they were probably in a lot more pain before it turned into gangrene, um because once it's gangrene it's already dead tissue. And you know, sometimes I would put like, sometimes I'd be working on the opposite leg, so not the gangrene leg but the healthier leg, and you know, you would like, I would put like covers over the leg if I could, to like try to help with the smell. But when you remove the blanket off of that leg, like you will get like pieces of tissue on the blanket because they're just like shredding off of the leg. It's like my number one thing that will bother me is when I have to work on a gangrene leg, and I've done it a lot of times but it never has gotten easier for me. Something that you could do as a tech to help you, not just in this situation but in any situation where you just like can't quite stomach the smell, is wear a mask. And then I would take one mask and I would like kind of put like that scented lotion on. And I know as a medical health professional, you shouldn't be wearing scents because scents can trigger a nausea response in your patient. Patients can be allergic to the smell. But in this, like, this is a special situation. I'm not walking around with like scented lotion on my mask all the time. This is like when I can't make it through the ultrasound because it's that bad. So like I would take my mask, I would put some scented lotion. Sometimes people put like Vicks, because you know, like that minty smell. But the only thing with the Vicks is your mask is really close to your eyes, and those minty, like the menthol fumes, will get in your eyes and your eyes will burn. So like that's happened to me before too. So I don't really recommend that, but I would just carry like a small, you know, like really strong smell, like Bath and Body lotion. Just rub it on the inside of your mask and then put another mask. So like you're kind of like sandwiching the lotion between two masks and then put it on your face. And I promise you, you will still smell the gangrene, but it just won't be as potent and as strong. But so keep that in mind as you're preparing your way towards externship. Maybe like that's one of the things you want to add, you know, like to your to buy list. I'm going to buy scrubs, I'm going to buy new shoes, I'm going to buy a bottle of lotion to take with me. And so, and then we're gonna, so this is gangrene, and then we're gonna talk about what albedolins is, and then obviously at this point the leg would have to be amputated because of tissue death. It says there is a high risk of amputation and mortality with PCD because the lower extremity veins are all right, sorry guys, I lost my place. Okay, so we're still on 429. There is a high risk of amputation and mortality with PCD because the lower extremity veins are capacitance vessels and hold a large portion of the person's blood supply. A large amount of blood is being taken out of circulation, which can lead to circulatory failure and lead to shock and eventually to death. So when you have this issue here, remember there's some sort of a blood clot proximally, and that's why the blood can't leave the leg. So the blood can't leave the leg. So what do you think it's going to do to the leg? It's going to swell it, right? So now you're holding a lot of the circulation blood that the rest of your body needs. You're holding it in that leg because it can't leave because the DVT is blocking it. So a lot of that blood is taken out of circulation, which can lead to other organ failure, right? So it's like the leg itself is, you know, painful, but that's not what's going to kill the patient. It's like the fact that you have this leg issue and the blood is being taken out of circulation. So like if you don't have enough blood circulating to your kidneys, like that could lead to death. It's more common in men, and it has a strong association with patients that have a history of malignancy, so cancer. The left limb is usually the one that is affected, And you want to know that the sonographic findings would be very similar to a DVT, but the patient's clinical history would have to be taken into consideration to help diagnose this rare condition. So, again, the ultrasound would be just like a DVT. So you want to think of would you think of the acute or the chronic? Only the acute, right? Because they said that this is associated with a severe form of acute DVT. So when you're thinking about what sonographic findings should I know for phlegmasia caerulea dolens, it's the sonographic findings that we talked about in part 1 of acute DVT. Okay, so our next topic is phlegmasia alba dolens. So we do know that caerulea dolens can lead to alba dolens. Well, alba means white, caerulea meant blue. So alba means white, which is the color of the affected limb. It results from an untreated caerulea dolens or PCD, where the DVT is so massive that it then compresses the adjacent artery. So first with caerulea dolens with the blue leg, the problem was that the DVT was so big, it was blocking the exit for blood, right? Blood couldn't exit the leg because of that big acute severe DVT. And so that whole leg was holding a bunch of blood in it. And that's why it had that bluish tone to it, right? And that's why it takes so much of the blood out of circulation and can cause like circulatory issues in the rest of the body. Well, if that DVT is really, really big and it's dilating the vein really, really large, that vein will start to compress the artery, because remember, arteries and veins are next to each other. So if you have this really big vein filled with DVT, so here's my big DVT, the artery that's next to it will also start to close off because of all the pressure from this big giant DVT that's like pushing onto that artery. And so it says, so now the artery is compressed. Now you're also not receiving any new blood to the leg. So when you're not receiving new blood to the leg, that's what turns the leg white. It says because the artery is constricting, not enough blood can reach the limb, so it appears white. This condition is also rare, and it also has a high amputation mortality rate, as does PCD. In addition to a DVT, sonographic findings would include the adjacent artery seen as a deformed shape with low color Doppler signal. So that just means you're going to have a hard time getting color Doppler in the artery because there's like no flow or very, very little flow in the artery. And an abnormal arterial waveform will be demonstrated. So abnormal arterial waveform is very vague. Like, you know, what does that mean, abnormal? That could mean anything, right? Well, you have to think of what it is. In this case, there isn't enough blood or blood at all going to that leg. So when you do a pulse wave Doppler of the artery, you're going to have like really small flow. So typically like arterial flow would be, you know, like higher peaks. Circulation in the body is always different. So when you do velocities anywhere in arteries, like they're all kind of a little different, but typically they're around 100 centimeters per second. Like that's not accurate for every vessel, but it's like a good starting point. Like it's very, very broad though, right? Like, so if we just say like, hey, most of the time blood is traveling in arteries at a velocity of 100 centimeters per second, if the patient has phlegmasia alba, the flow is going to be very, very small. So it's going to be similar to what you see there at the bottom of the screen here, at the bottom of the PowerPoint. It's not going to be like these nice, obvious high peaks. The peaks are going to be small. They're going to stay close to the baseline because the flow is going to be a lot smaller than 100 centimeters per second. So he just says abnormal, but you know, might want to take it a step further. Like, what does that mean? Because abnormal can mean anything. Okay, so I would have that information about varicose veins in my pocket. So definitely all the information that we talked about for DVT, right? That's how the chapter started off. That was like our first pathology, 100% yes. I also told you guys you have to write a lot of the information of how to check for valvular insufficiency and how to check for DVT. The protocols are the same, but there are certain tweaks or adjustments that we have to make depending on what the doctor is telling us to look for. That needs to go into your pocket notebook. Cerulean and alba, I wouldn't put. They're very, very rare. Like they're too rare for me to put in my pocket notebook. Will you come across this someday? Maybe, and that would be, like a really interesting case for you. Like I feel sympathetic for the patient, but for you, it would be like pretty interesting to come across that, but it's too rare for me to want in my pocket notebook. Something I am going to put in my pocket notebook is Baker cysts. Baker cysts are not that uncommon. We do see them quite often, and it's important to document them because patients do have pain. So a Baker cyst is a cyst that is found in the popliteal fossa. It's always in the popliteal fossa. If you think about it, your legs kind of go through a lot of the same repetitive motions, right? Walking, running, like these are your leg is doing the same motion over and over and over. So when that happens, sometimes you can form a cyst in the back of your knee, and patients will complain of like a tightness, or like they feel a pulling in the back of their knee, or like a pain. And so this is really common. So it says, for a patient with pain in the area of the popliteal fossa, the culprit may be a Baker cyst, which is also known as a synovial cyst. The cyst has a high association in patients with arthritis. Arthritis, just so you guys know, is joint inflammation. Or autoimmune diseases. Baker cysts can be an incidental finding. So that means you're not really like seeking out, hey, I'm going to scan to find a Baker cyst, but you kind of stumble across them because they tend to be really big cysts. And again, they're only in the popliteal fossa, so they're nowhere else, okay? They are not true cysts, but a dilation of the bursa. So a bursa is a fluid-filled cavity. In this case, it's a fluid-filled joint. So a true cyst, so a cyst like somewhere else in the body, let's say, like a breast cyst, that's really common. Breast cysts are really common. They have a lining. They have epithelial lining. So it's a lining or a shell, and inside of it is a fluid. That's a true cyst. Now, this is not a true cyst because it doesn't have the lining. Really what it is, it's a joint or a cavity, which we're calling a bursa. So it's like, imagine this space, right? This bursa. And because of the repetitive motion of walking or running, this cavity starts to kind of like get irritated, and it forms a fluid pocket. And so we call this fluid pocket a cyst, but it's not a true cyst because it doesn't actually have the lining. Like having the endothelial lining is a characteristic of a true cyst. So Baker cysts are not really true cysts, but we still call them cysts. And so it says, and so the reason we find them incidentally is because we tend to be looking for a DVT in the pop, and then we stumble upon this popliteal cyst. But there are techs that miss Baker cyst because you're not scanning in the full cavity of the pop area. So when you are scanning in the popliteal fossa, a note that I would write myself, a practice that you should do to make yourself a better tech is, don't just like, okay, let's say I'm scanning a patient and I want to scan the popliteal, the pop vein, and I put my transducer in the popliteal fossa and I immediately see it. So I'm like, oh yes, like I'm right on it, right? Like I didn't even have to do any work. Like I'm right on it, and I start taking pictures of it. That's cool, right? You found the pop vein and you can make sure there's no DVT or whatever, and that's cool. But like I always tell my students, take it one step further, be like a better tech. Let's not be mediocre. Sorry guys, sorry for that interruption. My cat is at the vet, and so I was just getting an update. But I was saying, when you scan the popliteal area, even if you find the pop vein right away, just take it a step further and really scan that whole fossa, that whole back part of the knee, because you may also find a cyst. And it says these may be hemorrhagic or rupture appearing complex on sonography. So they do tend to look a lot worse than they are. They usually are not clean cysts, so they're not completely anechoic. As you can see, this one has some like debris there at the bottom of it. They're like, they have like these really long, elongated, funny shapes. This one looks like it has a septation, like a line going through it, or a loculation is another way of saying that. They're like, kind of like dirty cysts. Like they're not completely anechoic. They look a lot worse than they are. Um, and they often bleed within themselves, which is why they're called hemorrhagic. And they are not connected to the popliteal vein or artery in any way. So when you find them, you want to make sure, something you want to write in your pocket notebook, is a lot of times they're so big, you're not going to be able to fit them on the screen. So they'll look something like this, right? They're like definitely coming off the screen. You can use dual screen if you want to try to get like a size approximation. And then you'll see like that the artery and the vein, or like the vein and the artery, I should say, because they probably switch spots. So vein and artery are not communicating. So they're like not connected to the cyst. This is the pop cyst. And like I said, you could do a dual screen if you want to get them both on the same screen, so you can like try to, measure it out. They tend to be like really long and just like kind of ugly in shape. But you do want to show a picture where you can show that they do not communicate with the vein or the artery of the popliteal, and they are completely separate. So that's important. And this is what that tech is doing here. They could have done, like I'm sure they took more pictures than this, but this is, I'm guessing, one attempt to do that. So that is a Baker cyst. And yes, I would put that in my pocket notebook. So we've been talking a lot about venous issues, right? We talked about superficial, we talked about deep vein thrombosis, superficial vein thrombosis, venous insufficiency, varicose veins, cerulean dolens. All of that had to do with the veins. Alba dolens, that one had to do with an artery. Baker cyst is just a cyst, so it didn't really have to do with veins or arteries at all. It wasn't vascular in nature at all. And now we're talking about aneurysms, which again is another arterial issue. So arteries are comprised of 3 layers, 3 walls, and we know that the tunica media is the thickest layer, and it contains a lot of collagen fibers, right? And so this is stuff that we've kind of been talking about. Well, anybody can be born with a weaker part of the wall. Unfortunately, there's no testing for this, which I always feel like if a physician was ever able to come up with like testing for an aneurysm, like preventatively test, it would be groundbreaking. But unfortunately, at this time there isn't, and so you could be born with a weaker part of the wall, and if you have high blood pressure and that blood is like pumping through that artery, the weakened part of the wall will kind of bulge out, because it can't hold on to that high pressure system of the arterial system. So it's like, look, I can't do it, and it kind of like balloons out because that's a weakened part of the wall. So on page 430, it says a weakening in the vessel wall can cause an aneurysm. True aneurysms are classified as being fusiform, saccular, or ruptured. So fusiform and saccular just has to do with the shape. As you can see, fusiform is a spindle shape, which means both sides, the anterior and the posterior walls are bulging outward, whereas saccular, it's only one, so it's always like a unilateral dilation. It could, in this case, it's anterior, but it could also be the posterior. Like you could have just like at the bottom a bulge at the bottom of the vessel, the posterior. So if there's like a uniformed bulging, right, both walls are bulging outwards, it's fusiform. If it's one wall only, then it looks like a little sac, it's called saccular. Saccular is also AKA berry, so like a little berry that's on a tree or whatever. And so it says a fusiform aneurysm is an overall dilation, whereas a saccular aneurysm is a protruding sac. A ruptured aneurysm is an emergency and occurs when the wall is so weak and thin that it bursts open. So if that happens, you can imagine that the patient will start leaking blood out, right? So like if this wall completely breaks out, the blood will start spilling out like into the body or wherever it is. And aneurysms are very dangerous, but you can imagine that having an aneurysm in the neck, like in the carotid arteries, in the brain, in the aorta, those would probably have the highest mortality rate. It says these patients, so when there is a rupture or a burst, it says that these patients will become hypotensive quickly. So that means their blood pressure decreases really quickly. And that's a big sign of rupture. You will hear that multiple times when we talk about aneurysms, that high blood pressure, blood pressure typically causes the aneurysm, but when it ruptures, the patients will have low blood pressure, so hypotensive. A pseudoaneurysm is a false aneurysm. There is no vessel wall surrounding it, and it is a break in the vessel wall. So I really dislike the topic of false aneurysm because there's always like a discrepancy. Every time you read the books, they kind of describe it a little bit differently. So okay, so we know what fusiform and saccular is. Those are just like the different shapes, right? And then we talked about what a rupture is. So like these black arrows where it's like signifying blood leaking out, right? So that would be a rupture. Sometimes there's like surrounding tissue. So like, let's say that there's like, I don't know, something else here. Like there's like a piece of tissue here and like another piece of tissue here. And it's like, forming this little pouch. Well, when blood spills out, right, because it has ruptured and blood spills out, it's just going to kind of fill in this little space, right? And so this little space doesn't actually have a sac around it, but it looks like it's a little sac because all the blood is kind of accumulating in one space. Now, so because the blood is being like held in one space by surrounding tissues, not by a vessel wall, is when we call it a false aneurysm. So it looks like a sac, it looks like it's an aneurysm that is intact, but actually there's no wall around it, right? The reason the blood is not, spilling out and going in all these crazy different directions is because of the surrounding tissue that's keeping it kind of locked in one place, but there's no actual like arterial wall around it. And that's why we call it a false aneurysm. Okay, so you guys want to know that, and this is the information on aneurysms. And we're gonna go to cellulitis on page 430, and so cellulitis is a bacterial infection of the skin. So it's bacterial infection of the skin. The symptoms are pain and redness. It can be differentiated from a DVT because the redness secondary to a DVT is usually localized. So if the patient has a red leg because they have a DVT, the redness will be in one part of the leg and it won't be like spread out throughout the leg. So if you, as you can see, the redness here is like on top of the foot. It looks like part of the ankle, like up the tibial shaft, right? So like they have a greater area of redness. It's more diffused and not localized, so it's cellulitis, whereas a localized or a focal area of redness would be due to a DVT. Redness from cellulitis affects a significant portion of the leg. Significant edema can be visualized sonographically, so the patient will have a lot of swelling in the leg, not only red but swollen as well. So it says significant edema can be visualized sonographically, and cellulitis has been described as having a cobblestone appearance. Sonography can also identify abscess formation and guide needle aspiration if needed. So let me show you what cellulitis looks like. So the patient would come in with like a very diffused red leg, and it would be very, very painful. It does really hurt the patient. I've seen patients be in a lot of pain from cellulitis because they have this bacterial infection that has spread over the skin. Good and bad. Like number one, bad because it's super painful and it's like usually the whole leg or a large part of the leg. Good because it's not a DVT. It's less dangerous. It can be treated with antibiotics. So that's pretty good. Like the treatment, I think, is a lot easier than if the patient had a DVT. But you're always going to see this cobblestone appearance at the superficial layers of the skin because it's within the skin. So cobblestone appearance, so if you guys have ever gone to, maybe you guys have it at your house, but kind of like entryways, like if you're walking up the driveway and there are these big stones, and the stones all kind of look like they're like puzzled together, like really nicely like this. And you're just kind of like walking up someone's driveway that has cobblestone. And if you wear high heels, you know, God bless you on that path, because you know you're probably gonna get your heels stuck in between one of the stones. But this is cobblestone, right? And so this is what kind of like the same appearance that you'll see in the tissue. You'll see the layers of tissue, they're all kind of separated by minimal amounts of fluid. So these little black pockets that you're seeing are fluid. Now, guys, I know we can see it very well on ultrasound, right? But it's very minimal amounts of fluid. So it's not a big pocket of fluid where you can put the needle in and like aspirate it to like drain the fluid. So you can't do a needle aspiration on cellulitis. It's treated with medication. Now, if you had a big pocket of fluid, we would no longer call it cellulitis. We would call it an abscess. So an abscess is a big pocket of fluid, and in an abscess, you typically can put a needle into it and aspirate it, which is what he was referencing at the end of the paragraph there. So this is what an abscess looks like. It's like a larger accumulation of fluid. And now abscesses are also they're comprised of different types of fluids. So they have a serous, like a thin, a very low viscosity, like kind of like a clearish yellow fluid. They'll have some blood in them. They'll have some like thicker fluid, which is like normally pus. And so an abscess reminds me of a really big, painful pimple, because it has like the different types of fluids in it. Abscesses, if they are not super thick with pus, doctors can put a needle into them and drain them, aspirate them. But if they do look a little like this first picture, this one here, this one does look like it's a little bit thicker fluid, so the doctor may not want to aspirate that one. But the other dual screen image, the fluid is more anechoic, which to me means it's either like lower viscosity, so like maybe the doctor can aspirate it with the needle. But sometimes if they think the fluid is too thick, they'll just send the patient to surgery and they'll like clean it up in surgery. If they think the fluid is thin enough to pull out with ultrasound, they'll aspirate it under the guidance of ultrasound. Well, I just want you to keep in mind that cellulitis is different than an abscess, because even though the tissues, the skin layers are being separated by fluid, they're being separated by very small amounts of fluid. So we don't really aspirate it under ultrasound. And like I said, it's treated with antibiotics. Okay, so on page 431, we're going to talk about treatments, and really like prevention is like the biggest treatment here. But prevention, the best way to treat a DVT is with prevention. So I don't know if that sentence is 100% formatted accurately. Because the part of Virchow's triad with the greatest impact is venous stasis, it is best to use a calf venometer or venometer pump fully to keep blood flowing. So it says, I'm going to spell it a little bit different. So it's here it says venomotor, but it's also referred to, I don't know if this really matters, as a venometer. So same thing. But this is a pump. So this lady here with this little smirk on her face, this lady here has those pumps connected to their legs. So they look like giant stockings, and they're connected to a machine. And there's a lot of tubes and like airbags in this this contraption, and it swells up and then it like releases air. It's kind of like a blood pressure cuff. So it like swells around your leg and then it releases air. And so it does this over and over. And this is usually used for someone who cannot get up and walk. So I see it a lot in patients that have just had surgeries. Maybe they just had a C-section and they can't really be up and walking about and getting that calf muscle pump. So this kind of does it for you as you're lying in bed, until you are recovering, hopefully. And then it says elevating also helps it to aid with gravity and getting venous blood back to the heart. Another thing that helps is compression stockings. Compression stocking keeps the veins at a small, like tight diameter, pushing the blood upwards and not allowing them to pool and to have to create stasis. So as ultrasound techs, you are in a profession where you are mostly on your feet. The sitting that you're doing a lot in class right now is going to be like nothing compared to when you are working as a tech. When you are working independently as a tech and you are responsible for doing all of the ultrasounds and you don't have anybody supervising you, so I'm not talking about externship, I'm talking about in your career when you're out in the world on your own. A lot of us used to wear compression stockings because they just keep that leg really tight. And so a lot of ultrasound techs have spider veins, unfortunately, and a good way to prevent it is to just wear the stockings before you get the spider veins. Once you get them, it's kind of too late. So if you want to add to your list, right, with what you should purchase, that would help you is compression stockings. They just will reduce the likelihood of you getting spider veins, which is really common in our field of work. We're going to talk about anticoagulation medications. So it says medications such as heparin are considered anticoagulants or blood thinners. So heparin is like the most common one. A lot of patients will tell you they're on heparin and this is a blood thinner. Although anticoagulants are a standard of care for acute DVT and are very effective in preventing a thrombus, these medications are not effective in dissolving an already formed thrombus. So usually patients are put on heparin preventatively. So if the doctor knows that the patient has a high viscosity of blood or like a high coagulation level, the doctor knows that the patient is more at risk for developing blood clots, so they'll put them on heparin preventatively. Or if they've had a blood clot in the past, they'll put them on heparin to not get a blood clot in the future. However, once you do have an existing blood clot, heparin is ineffective. So they say it's not effective in dissolving an already formed thrombosis. And then also a disadvantage of heparin is the blood thinning itself is both an advantage and a disadvantage. Sometimes patients are taking heparin to prevent them from getting blood clots, but if they need surgery, the doctor will have them stop the heparin for a couple days prior to surgery because your blood is too thin. And then you have the risk of bleeding too much during the surgery. So it's kind of like, it prevents you from getting blood clots, but it also puts you at risk for bleeding too much in the case of surgery. And so it says bleeding becomes a major risk in patients taking anticoagulants. And unfortunately, that's kind of like the thing with healthcare, right? You treat one problem, but while you're treating one problem, you may be giving yourself another problem. So heparin is not helpful in a patient that already has a blood clot. So if the patient already has a blood clot, they're going to use clot busters. So clot busters are called thrombolytics or fibrinolytics, and this is a clot that already exists. These medicines are effective in breaking up and dissolving a thrombi. Okay, he's going to go into great detail about the different types of blood clot of clot busters. Older medications and newer medications, you don't have to know that. Obviously that's outside of our scope. We really don't have to know that. It won't help you in any way. So we're going to skip down to the bottom where it says these agents can be administered systemically, which means given to you, and then it travels through your entire body. That's what that means, your entire body. It says they are a treatment for DVT to achieve patency. So we want to get rid of the DVT so that the vessel can be patent or open one more time and the blood can be passing through the lumen effectively. And then bleeding also becomes a major risk in patients receiving thrombolytics or AKA fibrinolytics. And then we have a thrombectomy on page 432. A removal of a clot is termed a thrombectomy. So ectomy means to like remove something. So what are you removing? The thrombo, right? The thrombus. So you put the words together and you can make sense of it. Ways to remove a thrombus include percutaneous mechanical thrombectomy and pharmacomechanical thrombolysis. Historically, a patient had to undergo a surgical thrombectomy. With newer advances in technology, less invasive methods exist. With percutaneous mechanical thrombectomy, the thrombus can be mechanically removed via a catheter inserted into the common femoral vein. This procedure macerates, which macerates means it thins and softens the thrombus and suctions it away and can be used along with medicines to prevent clot formation. So what I want you guys to know from this section here is that what the removal of a clot is called, it's a thrombectomy, and that how they are done now. So now they're done pretty effectively, and like it has like, it's very minimally invasive. So they cut like a teeny tiny incision in the inguinal area right over the level of the common femoral vein, and they cut into the vein, and then they put this catheter in, and it's hard to see, but at the end there's like this like little hook. So right here there's this little hook, and they hook the thrombus and they like pull it out, and this kind of acts as a vacuum, and so the thrombus will, here's the thrombus, it kind of gets pulled into this section, and then they just like pull the whole thing out. So this is a thrombectomy. So that's kind of what you need to know. And so everything else, if you guys should be reading the topic entirely. If I've talked about it, if I've totally skipped over it, it's because it doesn't really pertain to ultrasound, and it's okay for you to totally skip over it. But the sections that I have talked about, you have to dig a little deeper than just the highlights, especially to prepare for something that you're going to be tested on so much. So make sure that you guys are studying effectively, creating your study content, breaking it down. The best way to study is to speak out loud. If you can talk about it, if you're explaining it, you can you're going to be able to retrieve that information a lot easier for your test and be able to successfully complete your test with a grade that you can be proud of. So let me know if you guys have any questions, and enjoy the rest of your day.